Good afternoon. Thank you for joining today's briefing from the St. Louis Metropolitan Pandemic Task Force. As usual, we'll go through the data briefly to see what's happening locally, and then we'll talk about some of the topics that have been coming up on chat sites and questions that are submitted to the task force. This is the case curve for the U.S. The curve on the left shows the overall cases, and on the right, deaths. For the case rates, there's clearly been a decline. So we've seen ongoing recovery in the southern parts of the state. We'll look at a map in just a minute, but we're definitely on a downward trajectory. Deaths are not quite at that pace yet, and there's a little bit of a bump on the far right as Arkansas reported a group of deaths all at once. So that spike up is just probably a data artifact. This is what the map of the U.S. looks like. Again, just a reminder that the darker the color, the higher the case rate, and that's on a population adjusted basis. Right now, Alaska's certainly been in the news because of their heavy burden relative to the population size. But if you look at the continental U.S., it's easy to see that the southern areas that were most heavily hit earlier in the season are now looking pretty good, and a lot of the activity is concentrated in the north, particularly the Mountain West. We are also continuing to see that a number of the big metropolitan areas just have not seen the same kind of surge with Delta that some of the other parts of the country have seen. This is our overall epidemic curve for St. Louis. Again, our case rates are also starting to decline. Right now, we're about 40% below where we reached at the peak in early August, and that number continues to go down. That's reflected in the weekly percent change in new cases. There's been a nearly 12% decline in the week-over-week 14-day rolling average. So that reflects the same kind of information we saw on the case curve. And our R number has stayed below 1. Again, a reminder that when we're below 1, the size of the pandemic in our region is contracting. If it's above 1, it's expanding. So we've had several readings in a row now that have kept us down below that important 1.0 threshold. Similarly, our hospital admissions are also declining. We're down about 40%, maybe nearly 50% in some hospitals if you look at the 7-day moving average. So again, very welcome news to see continued decline off of that peak. And that coincides with the number of people who are currently hospitalized. So we're down below that 300 threshold, which is also very encouraging. I will point out that case rates are still 5 times what they were in June, and our hospital rates are still 2.5 times what we reached at our nadir. So we're not done with this wave of the pandemic yet, but we're certainly going in the right direction. These are the current hospitalization numbers: 299, just over 100 in the ICU with 71 on ventilators. Last week we administered regionally 367 doses of monoclonal antibody, which are currently the most effective strategy we have for preventing progression to serious disease. This shows our mortality rate. The number bumped up a little bit over the weekend, and we were at an average, 7-day moving average of 7. That's still off the peak. We do expect that this number will slowly make its way down also as hospitalizations continue to decrease. And the often asked question, about 3/4 of patients who are hospitalized right now are unvaccinated. There's a slightly larger fraction that are vaccinated than we've seen in previous weeks. And part of that is that many of those patients are immunocompromised or have other illnesses that put them at risk, and they tend to be in the hospital a bit longer. But we'll also see, as the number of people in the region are vaccinated, we'll see an increasing fraction of the hospitalized cases will be breakthrough cases. That's just the nature of things. Our pediatric admissions are down significantly this week, fewer than 10 for the first time in some time, with only 4 in ICU. So that's another encouraging finding. And yesterday we discharged 58 patients, pushing us up very close to 29,000 cumulative discharges in the 4 task force hospital systems. Projecting ahead, we are staying on that model that has been projected for several weeks now on a steady decline. And again, barring the entry of a new variant in the environment or to some change with weather, we are headed in a nice direction, hopefully to get back into the range we were in June by the end of the year. This is the curve for the ICU, a little bit less closely adhering to the model, but still on a downward trend. In terms of vaccination rates, nationally, we're still at about 2/3 of the country have initiated a vaccination regimen. In St. Louis, we're getting very near to having half the population having completed a full vaccination series, and almost 55% have had at least 1 dose. And again, this is total population, so it includes those age groups that are not yet eligible. So while it's not where we would like it to be, it's certainly nice to see these numbers creep up. I won't try to go through the county by county data with you. You can certainly look at that on the website. I will point out that St. Louis and St. Charles counties are both nearing 60% of the population, total population, having initiated or completed a vaccine series. That's the end of the data wrap-up. So again, the overall pattern is very promising with the decrease in case rates and hospitalizations, and let's hope that that trend continues. Moving on to the questions. So the first one I think I've already answered. Do we expect numbers to continue to decline back to early June levels? I think barring some interruption due to a new variant or a change that we're going to talk about in a minute from the weather, we could well see getting back to those June levels by the end of the year. That said, as the second question asks, do we expect to see a winter surge again? We really can't say for sure. Part of what fueled the winter surge last year was the appearance of the Alpha variant, which at that time was substantially more transmissible than its predecessor. So that was more like the upswing we saw in August and September in terms of a new variant taking over. But as people start to crowd indoors and we see less distancing, we could well see a new surge. So it's a little bit too early to declare victory. The next question has to do with pediatric events declining. And yes, the short answer to the question is I do think these are very encouraging. Again, we're not out of the woods. A higher proportion of the cases that are occurring right now are in kids than they have been at other times during the pandemic. So we'll continue to see individuals hospitalized who are in the pediatric age range. Fortunately, most will do very well with COVID and not have to be hospitalized, but there will be some kids who have predisposing illnesses and some kids who don't have any apparent illnesses who will wind up with severe disease and in the hospital. The next question concerns deaths. They've also been declining. The short answer of that is it's a numbers game. So there are really 2 reasons. One is the overall rates of new cases are going down, and as that happens, we will see mortality rates decline. Also, if you looked inside the vaccination numbers, you can see that a very high proportion of individuals who are at risk because of older age or medical conditions have now been vaccinated. And so that is one other place we'll see a reduction in death rates. That said, individuals who are unvaccinated still remain at significant risk of bad outcomes, hospitalization, and death. And we encourage everyone to get vaccinated if they haven't done so already. The next question is, what are my thoughts about COVID treatments like monoclonal antibodies and the new drug announced by Merck? Well, both those therapies, the monoclonal antibodies currently being used and the new drug announced by Merck, have been shown to be effective in mild to moderate disease and preventing progression that might lead to hospitalization and more serious outcomes. There has been no head-to-head comparison, so we can't really say whether one is better than the other. If you look at the data that's been reported for them, They're comparable in terms of the number of individuals you would need to treat to prevent one hospitalization. That said, obviously an oral drug would be much easier to administer and much more convenient for the population. Until we have action by the FDA on that drug, we will continue to push all individuals with newly diagnosed COVID to ask their provider about monoclonal antibody therapy. The next question is, how much longer will it be necessary to mask in public? Just to clarify, first of all, you don't always have to mask when you go outside. Certainly if you are in the outdoors and can keep a good distance from others, there's no need to wear a mask. If you're in a small barbecue in your backyard with other people you know are vaccinated, the mask isn't necessary. It's when you're going to be in close quarters with others whose vaccine status you don't necessarily know about, or if you're going to be indoors with a number of other people. How much longer we have to do that depends on how quickly case rates come down. If they continue to decline and they get down to where they were in June or lower, then I think we'll be in a position to start easing off on masking and some of the other restrictions. But we really can't predict that yet, and we need to wait and see what happens with the colder weather. The next to last question concerns whether we're expecting a busy flu season, and then what about shots? Internationally, flu seasons have tended to continue to be mild, and that is because in most places masking and distancing are still being pushed pretty aggressively. There is one school of thought that because we didn't have a flu season last year, people's immune system might not be as geared up to tackle the flu if it appears. So there are some who believe we could be set up to have a more severe than usual flu season. I think both lines of reasoning are conjecture at this point. We do know that there are cases in in the U.S. of influenza, correcting that, not St. Louis, cases in the U.S. of influenza, and we're watching that carefully. We do strongly recommend that people get flu shots, and they can be given at the very same time that people get a COVID shot, whether it's a primary series or it's a booster shot. Just a quick note about boosters. Again, we're encouraging everyone to get their booster if they're over 65, if they're 50 or older with diseases that might put them at risk, and if they're younger than 50 and they have diseases that put them at risk, they should strongly consider getting a booster, although the strength of that recommendation is a little bit lighter. Are there different kinds of COVID tests, and do you recommend receiving one over the other? Well, the PCR test that involves a swab in the nose is still the gold standard. It has a higher sensitivity and specificity than other tests, which means if it's positive, it usually means you're infected, and if it's negative, it usually means you're not. There are other tests, such as the home test that's being pushed by the Biden administration, and there are many versions of those home tests, and some are better than others. They're not quite as sensitive or specific, even the best of them, but they do have a role. If you are home and you've been exposed and have symptoms, and one of those home test kits is positive, then you probably do have COVID. And if the test is negative, then there's a pretty strong chance that you don't have COVID. So they are useful in that regard. We do not rely on them in the hospital for testing because there's still some false positives and false negatives. The problem with broad use in the U.S. has been one of availability and cost. So they're still not as broadly available as they are in some countries, and they cost some money to run. So we're not quite where we need to be with testing alternatives, but that is in progress. So with that comment, I will finish out today's briefing. Thank you very much for listening.